transparency, utilization of international experience and expertise as we are doing today, appropriate funding, assess users' levels of satisfaction. We have to involve people if we want them to get involved in the implementation of the new decisions and the new policies. Equal distribution of resources is required, centralized planning and policy making, and decentralized implementations and services provisions or delivery. Systematic selection and update of national specifications list or drug list or essential drug list or national formulary list, reliable data, central public sector tenders with districts' representative participation and with districts or hospitals purchasing. Coordinated central inventory management of distribution and redistribution system. It has to be central. Empowerment and monitoring of private sector and enforcing commercial agencies' responsibilities. So this means that we all know the case diagnosis, because I believe the slides which I presented, they have been presented by the slides or the presentations of my colleagues. So we will know the case diagnosis. And I believe we also know the treatment. So what's the challenge? The challenge in the future is how to translate these into actions, into implementation, into practice. So we should not keep lamenting or crying for our situation. It's a really bad situation, but we have the key for the future today. We have to go on. We have to make actions. I have to say this in Arabic. نعلم نحن جميعا نحلم بالتغيير. Sorry, I'm emotional because I believe after the revolution we have to change. But what happened? We just made a political change, but the situation is continuing as it is before. It has not been changed, and it will not change if we don't decide and commit ourselves to change. So نحلم جميعا بالتغيير ببناء ليبيا الحرية، ليبيا العدالة والتقدم والرفاهية. ولتحقيق ذلك لابد أن نتملك الإرادة. لا، ليس ذلك فحسب. لابد أن نعلن التزامنا بذلك برلمانا وحكومة وشعبا. لا، ليس ذلك فحسب. لابد أن نخطط ونعمل لتحقيق ذلك. لا، لابد أن يبدأ كل منا التغيير من ذاته. سوف لن تتغير ليبيا إلا إذا تغيرنا نحن. ليس قولا فحسب بل قولا وعملا. كل منا يريد ليبيا أن تتغير ولكن لا يريد أن يغير من نفسه. None will change Libya unless we all change it, unless every one of us changes it from that to this. So let's work forward towards a brighter future for them. By the way, 3 of them are my daughters. Thank you.
Thank you very much, Dr. Al-Bast. I think we will leave the questions until the end of the session. Gloomy situation, but we'll get out of it, I hope. Next speaker will be Dr. Paul Akribiyadis, who is going to take 2 talks in one, hopefully. The first one will be WHO, yes, WHO essential list and generic drugs. And the second one will be drug selection and purchases. Dr. Paul Kriviadis is a pharmacist. He is a long experienced with the United Nations, and he's being the coordinator of procurement and contracting services at the World Health Organization. Welcome, Dr. Paul.
Thank you. First, let me thank the organizers of this meeting. It's really a pleasure and an honor to be back here in Libya. And thank my colleague, Dr. Faturi, who did an excellent presentation, which I hope to be up to his caliber. And many parts, although we never met each other, are complementing each other. Let me start with a very simple declaration, which is the Human Rights Declaration, where every citizen, it's a fundamental right for every citizen to have access to medical and essential care without any distinction of economic or social condition. In furtherance, in 2000, the authoritative general comment detailed the right to health through 4 concrete steps: access to health facilities, availability of medicines, their appropriateness, and assured quality of medicines and services. The vision of the Minister of Health of Libya since the revolution is that all people in Libya have access to the essential medicines and services they need, that the medicines are safe, effective, and of assured quality, and that they are prescribed and used rationally. Libya, as you know, is a welfare state where the health and education are free and provide universal coverage to all the population. However, these services have weakened and aggravated by the conflict. The drug procurement and supply has been badly disturbed, exposing the weaknesses that existed in the system and contributed in the cessation of the primary healthcare services, peripheral and central hospitals. At the same time, the weakness in the drug management system, including the information monitoring, the supply, logistics, led to a large wastage and expiry of drugs. We all know that it's not enough to draft a pharmaceutical reform policy and formulate these changes that are required. We must study how to put in practice and who is likely to be for and against the reform proposed. In any change of situation, you have people for and you have people who are be against it. The problems of shortages, non-availability, irrational use in the public sector are often similar in most of the countries around the world. Different interventions and strategies can be implemented to address these problems. However, through international comparisons, the following state policies and objectives are common. First one, to make available at all times and to all health facilities safe, effective, and good quality of essential drugs obtained at competitive prices. To promote the rational use of drugs. To promote the generic names. The generic names are based on the essential drug list, which the WHO has developed almost 30 years ago in 1977, and when it was developed for the first time, it included less than 200 medicines. Today, 2011, a revision has been made and it contains almost 400. These are the basic medicines that should be available for the whole population in every part of the country. As my colleague said, all European countries have essential drug lists. This is the basic. And the countries have between a range of 1,000 to 1,500. Unfortunately, Libya's list today of imported medicine are more than the double of any developing country. We should improve the distribution systems from the central to the most peripheral locations, including allocations, distribution, stock management. Establish an efficient logistics information management system, an inventory, to know exactly which medicines are available where, what quantity, what is due for expiry, and if it can be moved from one hospital who doesn't need it to another hospital or health center who needs this medicine. This is the only way to reduce the waste and the shortages. Strengthen health education and research with particular reference to the use of medicines. Establish a solid drug management authority with administrative and financial autonomy. When you have a strong management authority, everything is put in place. As my colleague said, you need law, you need rules, you need regulations, you need updating them regularly. Enforcement of the policies and procedures of the National Medicines Regulatory Authority. The policy should further outline the steps to be taken for the implementation. It's very nice to establish rules, regulation, and declare policies if you don't know how you will implement them. First one is the adoption of an up-to-date national pharmaceutical policy. The selection and adoption of a revised essential medicines list, the one in Libya is very old and has never been updated. Review of the nomenclature. The nomenclature we mean to define official nomenclatures and use of medicines in the primary health care, in the regional hospital, central hospital, and in the private institution. The preparation of an essential drugs formulary, which will provide for each category of drugs indications, cautions, contraindications, side effects, etc. Review of the present procurement system. We cannot have an efficient drug management system if you don't have an efficient procurement system. The medicine should be purchased, distributed, be of good quality at the time needed. In order to review a procurement system, you can establish a checklist which will provide transparency, guidance at every stage of the public procurement cycle, from the needs assessment to the contract management. In general, the procurement cycle is defined as three main phases. The first phase is the pre-tendering, which include the needs assessment, the planning, the budgeting, the definition of the requirement, and the choice of the procedure. Second phase is tendering, invitation to tender, evaluation, and award. The third phase is the post-tendering, which includes contract management, order, and payment. These three phases provide a clear chain of responsibilities along with an effective control mechanism. Some consideration should be given to a system that has been established in some other parts of the world and is called the pooled procurement system with a well-functioning between neighboring countries. This has been done in the Eastern Caribbean services, which includes 9 Caribbean countries, which they have grouped together their needs. They do a joint tender, a joint adjudication, quality control. They procure, every country places its orders separately, but they have better prices, and they can exchange the products in case of needs and shortages in one country or another. And thus they reduce also the waste and destruction. Or the Gulf Cooperation Council group, which you know is composed from Saudi Arabia to the Emirates to Dubai, and a few other countries. They have done this 15 years ago and is working successfully. Maybe you can envisage, until your system is up and running properly, to cooperate with a neighboring country and join them in such a tender. Review of the quality assurance system. Update, revalidate all suppliers' registrations, GMP, GDP, licenses, products dossier. This would be also necessary in order to make sure that all your suppliers' data that you have, which are obsolete, are updated. Some companies may drop off, new ones come in, update all your records in order to make sure that you get quality drugs. Training in rational prescribing. Provision of drug information, both to doctors and patients for guidance. This information and education, you can use publications, brochures, newsletter, electronic and folk media to carry out the messages to the widest possible audience. You have to be transparent and you have to inform the population of what's going on and what you are doing. Development of standard treatment guidelines for a number of most common diseases. to be given to prescribers working in the dispensaries and the private healthcare centers, to monitor and evaluate the program management and its implementation through regular surveys using established core indicators. Contents and advertising of promotion of drugs to the medical doctor should be controlled by the state. It should not be loose. Factors that will determine the success and sustainability of such a program development and the reform. First of all is the identification of a highly motivated core group. Availability of few dedicated persons and powerful people who can interface between the political leadership, the bureaucracy, the health professionals and experts are necessary in order to have an open discussion and move your things forward. Flexibility of operations and innovative move, think out of the box. Establishment of a special committee with statutory authority and innovative leadership. In this committee, you should have also some finance experts and law people along to advise you. You need to have committed and motivated government staff. The change of mindset is not easy. They need to be motivated, technically trained also is important. Repeat dialogue with all stakeholders, frequent regular meetings, exchange of information, objectivity in assessment, positive criticism. Don't criticize just for the sake of criticizing. If you criticize, also try and give the solution. And transparency is also necessary. Building technical capacity. A result of an ongoing training programs, a large number of experts will be made available all over the country in all sectors related to the different areas of procurement, logistics, distribution, quality assurance, and rational use of drugs. Further technical expertise in monitoring and research of the program on rational use of drugs could also be applied in any other program. Another point for success is a bottom-up approach. You need to start from the root and go higher up. This approach should be applied by participatory methods of all the stakeholders in the planning, implementation, and particularly with the persons and entity concerned. Thank you.
Thank you very much, Dr. Paul, for sticking to time and actually even finished before the time. I think we can allow a few questions now for both speakers. If anybody has a question. Before that, I have two announcements to say. First is about the workshops tomorrow. The invitation is open to all. There is no selection. That's number one. So everybody who's interested is welcome to attend. And we apologize for not distributing the handouts for the workshops today. We will distribute it tomorrow before the workshops, hopefully, when the photocopy machine is ready. Now, any questions? Yes, please.
First of all, I want to thank my colleague, Dr. Abdulwasel Fitouri, and Dr. Paul for excellent presentations. It's a disaster. The pharmaceutical sector in Libya, it's really a disaster, and it's deteriorated in the last 10 years, even maybe before that. I graduated in 1990, and at that time it was not really bad, but after that, just from 1995, it deteriorated very quickly, and it's a disaster at the moment. And I agree with Dr. Abdelbast about the national drug policy. That's what we need urgently at the moment. The other thing about the quality control, I think I disagree with you about the quality control systems in Libya, because it's impossible. If we say, Dr. Paul, he mentioned there are 400 items in the essential list. It's impossible for a small country like Libya to have a quality control for every single one. So, and it's impossible actually. I work in the pharmaceutical industry, and the slogan we say, it's impossible to check the quality into a product. You have a product there now. You can't check the quality of the product. The quality product starts from the raw materials and process, and then at the end you check. Okay, so the important thing is just we need to establish a body which is like FDA, or in Ireland we have Irish Medicine Board, which looks after filing, registrations, auditing, and customer complaint. They accept customer complaints if they have any medicine lack efficiency, and the doctors as well can fill a forms, says we have that batch doesn't have any effect, and then that body can investigate deeper and deeper, and then can contact the producers. So it's very important actually to establish a one body. Now, Dr. Abbas mentioned we have detached bodies. They're not linked, like registration in the Ministry of Health. We have Food and Drug Control Center, and everybody works differently. The drug centers issues drug release, and the Department of Pharmaceuticals in Ministry of Health issues drug authorization. That's not the good way. The important way is just to have a single body which looks after filing, and I would say as well, not only accept the 400 items in the essential list. I will open for all drugs available in the world to be filed once they show they are safe, efficacy, and produced in a very quality and in a quality assurance way. Thank you very much.
Any more questions? في دكتور بعدين.
السلام عليكم ورحمة الله وبركاته. دكتورة نجاة أحمد الكوشلي. I have a small note, but it's very important note. We need to encourage the investors to invest in pharmaceutical industry in order to manage the needs gap and to deploy resource in this important industry. So we must take care for this note. Thank you.
Thank you. It's rather a note. Yes, Doctor there. دي شكرا.
Thanks. Just, I'd like to comment on the, we are in the, what we call the forming stage. We passed the storming stage. We have to accept groups. And in a few years' time, we'll be in a teamwork. So, for example, if you have groups in different parts of Libya, that should be acceptable. This is a natural phenomena. It happens after any revolution. It passes through different stages. Forming stage, storming stage, then norming stage. Hopefully that shouldn't be taking a long time. The next stage, which is the most important, is the performing stage, where we really perform very well. So it's nothing difficult, it's nothing impossible. We have to accept the fact that groups should be fine working separately, whether in Tripoli or in Benghazi or Misrata. That's acceptable everywhere. Just takes time to unite, like in conferences or meeting. Thank you very much.
Thank you. دكتور في سؤال أسامة.
السلام عليكم الدكتور محمد المجبري. Regarding the Dr. Feitori, first speaker, thank you very much for the talk. I would like to be practical because we go to meetings and nothing practical comes out from these meetings. So, for example, you made excellent recommendations in broad lines. I would love you to write these in short points, and we discuss them in the future and next days in the workshops, and we take these papers and possibly sign them and give them to the Minister of Health. These are our recommendations, and we want you to implement this, and this is the outcome of this lecture, for example, and every lecture and every discussion we have to make particular points, very short ones, very clear, and the Minister of Health have to make an effort to implement these points. Thank you very much.
Thank you. That's the purpose of this conference and the workshops in the next few days. We'll be discussing it and writing it in black and white for the government, hopefully.
Assalamu alaikum.
Sama?
Dear Professor, I heard you talking about 400 drug. Is it drug which covering the whole diseases in our books, or there is another drugs?
Well, the essential drug list is the core of a list. It's not the Bible. These are the most used and basic medicines that every country should have. And it covers the most common diseases. These are the 400. To give you an example, WHO has established two type, along with other sister UN agencies, 7 UN agencies in general and NGOs, two type of kits. One, what we call the emergency trauma kit, which is distributed during war conflicts, zone areas, natural catastrophe, earthquakes, and which we brought also in Libya during the war. And this contains 55 medicines, which are used during emergency. We have another kit, which we call the emergency health kit, to serve 10,000 people when you have displaced population, big earthquakes, and you have camps. And this contains 85 drugs. When we say the essential drug list, this is the core and the basis. The countries, all the developed and industrialized countries, have between 1,000 to 1,200. They start building on this and expanding. This is the core available in the rural and the primary healthcare centers and the periphery. Then we go, you increase the type of medicines to the regional, and when you come to the central, the specialized hospital, you add drugs which are specialized. You don't need to have a specialized anti-rejection from transplant in a small village. This is in the specialized hospital. These 300 are the core, and you build on it. Today, Libya has more than 3,000, which it's ridiculous. And this is not because of anybody's fault, is that this list has never been updated or revised, but they are adding, and you have reached a stage. So everything has to be reviewed and reorganized in a certain way. Just to reply to the pharmacist colleague who raised the question on the quality control, no country in the world checks every pharmaceutical. The basis is to have a solid dossier during the registration of the product, where you review all the qualifications and you do spot check analysis on and off on a series of products. You will not start analyzing every batch of aspirins which comes in the country, or every batch of Panadol or ibuprofen who comes in the country. You take few products and you analyze on and off.
Thank you very much. If there is no more questions, I think it's about time to have a coffee break. We'll make it a bit shorter because there is another session of another hour.
It's okay, is it? It's 40 though. It's 40 though. Okay. Thank you. Okay.
أولا السلام عليكم ورحمة الله وبركاته. I think for the sake of time we need to start. We have a very interesting session today, this evening. human resources. I think we need to hear a lot of knowledge, a lot of things about human resources. We have a very distinguished speaker to start the session with, Mr. Chris Bourne, a healthcare specialist in the UK Trade and Investment. Mr. Bourne is an experienced chief executive from the National Health Service in the UK, and he is now supporting UK organizations to provide support to health service in Libya and across the world. Mr. Chris will speak about the ABC of human resources. So the time is yours, bro.
Thank you very much indeed. Shukran. Salam alaikum. I'm very honored to be here. I think the sense of excitement there is to try and create a fantastic new health service and health system for Libya is, you can feel it in the room. I've been feeling it all day. I think it's a fantastic opportunity. So we're very pleased and honored to come from the UK to try and share some of our experience and see how we can help and how we can introduce you to organizations who might be interested in coming to help with the great adventure you have to create this fantastic new health system for your people. This is an interesting subject because it's about the staff, the professionals that we need to run a health service. And we know, don't we? We know who we need. It's not a difficult question. What staff do we need? Some doctors, some nurses, some therapists, some technicians, some administrators, some support staff. It's simple, isn't it? But I think our experience has been that maybe it isn't quite so simple. Because in the end, we need, if I can find the right, the down, that's it. We need the right people in the right place, with the right skills, and at the right time. And of course, we need them not to cost us too much money. So it's a complicated question, really, about do we need more primary care doctors? Yes, I've heard that we do, but how many more? And do we need them all to be the same? Or can some be physician's assistants who aren't fully qualified specialists in primary care, for example? How many specialists do we need in particular areas, such as, say, dermatology or diabetes? How many do we need? And again, do we need them all to be consultant level, or can they be at different levels? What sort of structure do we need for the career of a doctor, for the career of a nurse? How many specialist nurses do we need? Do we need a lot of specialist nurses who know all about diabetes to work in primary care? Probably the answer is yes. I was talking to someone over coffee about mental health, and he was saying there is one person in Libya qualified in cognitive behavior therapy. And given the amount of trauma, mental health trauma that we've been through, that you've been through, and we've heard about this afternoon, then that sort of short therapeutic approach is necessary. So we know we need a lot of qualified and specialist skills, and we know we need a lot of people to support it. So the question is, how do you get the right staff in place? Well, as everyone else has said, you need to have a health strategy, first of all. You need to know what your health needs are as a country, which we've heard a lot about today, and you need to know how you're going to respond, what the strategy is going to be for the overall health service, and design what services you want. Are you going to give 90% of your service in primary care? That would be what we'd expect, to give 90% of health service in primary care. Only 10% in hospital. Hospital's expensive. You'll spend more money on hospitals proportionately, maybe 30, 40, 50% on hospitals, but 90% of the care and treatment would happen in primary care. If that is your design of your service, then you're going to have to develop your primary care staff. So knowing what your service is, and indeed knowing how much money you want to spend on it, is going to be important, because again, thinking about the range of levels of qualification. It isn't just about encouraging everyone to have a career. It's about knowing how many people you want at the top level of qualification and at the bottom level of qualification. Even your support and assistant staff need to have some qualification. And the question is, what are the levels you want to have? Now, in order to do this, I think you have to have some data and information. Because if you're going to go to the universities or to other colleges or health education providers, then you need to know how many staff you want to be produced. It's easy to create too many. I think all countries, including the UK, have created too many staff in some areas. At one stage, we had too many physiotherapists. We've probably got too many hospital doctors coming through our system. We haven't got enough primary care doctors coming through our system. So you have to really be careful that you're not just letting people follow their own interests. You have to control what the numbers of people that you train. And then you have to make sure that you're getting the right service from your education providers, from your universities and colleges. And of course, when you've got your staff, as we've heard again today, you need some form of regulation to make sure that patients are safe with those staff. Are patients safe with all your staff? I'm afraid we've heard today that maybe not all of them are. So making sure that every member of staff, whether they be a pharmacist, a doctor, a nurse, a therapist, is safe to work with the patient, that needs quite a clever regulation system. So let's talk a bit about how we can achieve these functions. Now, we've in the UK decided that we need to have a special centre for planning and profiling, identifying, finding out what staff we need. And the Centre for Workforce Intelligence is actually provided by a consulting company, Michel, and they are providing under contract to the Department of Health these services. So they're looking at how to model things, how to come up with various scenarios, and how to scan the horizon for what might happen in future. Are we really going to have the same structure of services and the same structure of staffing in the future that we've got now? Probably not, but what is it going to be? Certainly this issue of primary care versus hospital care is going to be a key question. This gives it in a bit more detail. So it's become a very scientific subject, this business of workforce planning and workforce profiling, with real detailed research, lots of engagement and involvement through workshops, through Delphi exploration, through wide consultation websites and so on, in order that we can get clear what sort of service, what sort of staff profile we're going to have, and then, of course, working up a model from which you can get your data to know how many places and how many people you actually want. And of course, you then need to consult on that again, and then you need to check it with the politicians as well. Because the politicians will have a view too, the government will have a view too, about what sort of a health workforce it wants. And only then will you really get a sense of what you need to supply, but also what you need, whether that supply is going to be there. Someone once said to me, if we carry on as we are, every single person leaving school has to become a nurse. Now, we can't do that. So we're going to have to find a way to provide services, not just with the same level of professional, fully qualified staff, but a much more mixed group of professional staff and support staff. And indeed, a range of other skills. People who can assist in an operating department, for example, not just doctors and nurses. Now, we can even go down to further detail. We can take every pathway and look at the staff that are needed. And the Centre for Workforce Intelligence has got some toolkits, which it could obviously work with you with as well if you wished, to look at how you not only design your care pathway, but design precisely the staffing you need to go with that care pathway. Now, of course, even when you've understood what your workforce needs to be, you still need to decide what exactly your workforce is going to be in each individual organization. So we are asking each, as we always do, each hospital, each primary care organization to tell the government what staff they think they will need in the future, because people running services need to have a say in what service they want. And only from putting that information together with all the intelligence we've had, the overall strategic framework for where we think we're going with our services and our workforce, and then checking that against individual organizations to say, what are you planning for your workforce? And out of that, then we know what skills and development of staff that we need to have, which can then be commissioned from the providers of education, but not only the universities providing tuition, but the organizations providing the placements for the experience of the people in training. And our view is that that has to be also governed by a sense of what is that education trying to produce. So what is the educational outcomes that we're trying to get? This is the very high level version, but clearly it is possible to start defining some indicators of what will be successful education. Now clearly what we're trying to get is an excellent experience for patients from these staff, but also that the staff should be satisfied with their job, with their experience of being a professional and indeed before then being a trainee. And that those staff are able to be effective with patients and safe with patients. So the headlines are that we need to have excellent education, staff who are competent and capable, so they have to be selected well to start with, that they are adaptable and flexible. The role you start with now will not be the role you're doing in 40 years, 30 years, even 20 years' time, probably not even 10 years' time. So we need staff who can adapt and be flexible in their role, but also in how they work with the team of people around them. We need them to have the right values and behaviors. We could talk all day about how to get the right values and behaviors. We were talking yesterday with one of your very senior policymakers, and she said that it could be 2 generations before the values and behaviors really develop and fully change in Libya, because there's been a long culture and tradition that may need to change if we're to get full responsibility from all the professionals and indeed a new sense of medical ethics and clinical medical ethics into all professionals. Now that's quite a dramatic statement, but developing those values and behaviors in the way that you want for your country is a critical part of education. And indeed, can you widen participation? You have a lot of foreign staff working here, but presumably you're interested in moving some of those 30% or 26% of unemployed people in Libya into the health service as employees. So how are you going to encourage them to take part? What's going to make it possible for people who may not have thought of healthcare as a profession to come into the profession? So I think it's very important to think about what your education is designed to achieve. Does it put people off, or is it going to widen participation? So that's workforce planning, which then produces a plan for how many staff you need to educate, and then produces the commissioning of education from universities and colleges. As I said, you also need to make sure that people are safe in their practice. And so having a regulatory system for your workforce is critical. And I think we're still learning about this ourselves, but clearly having a series of professional bodies, Royal Colleges, for example, that say these are the competences you need to become a member of our college, to become a professional that's accredited to work with patients, is absolutely critical. I think knowing precisely what will make you pass your training, but also that the training provider is suitable and the place where clinical placements happen is suitable. That they're not just using a trainee to fill some job that needs to be done, but is actually providing a high-quality experience of learning for that trainee. There's obviously making sure that people stay up to date, because healthcare changes very fast. So putting in your evidence that you've been staying up to date through learning conferences and so on is critical, and a way to test that in every person. And then increasingly we are bringing in revalidation. So you cannot carry on practicing beyond 5 years unless you can prove that you are still a competent, qualified professional. That's a big system, and it's one we're just bringing in. And clearly underlying all this is what is the behavior, the attitude that you expect all health professionals to have. I'm sure we could have a fascinating workshop just tonight to write down what you think the right behavior is for a professional in the health service. So we have this written down, and I think it is something that we feel lucky about, that so many of our professionals, a few very bad ones are not, but the majority of our professionals seem to have this knowledge and understanding of what is the right way to behave most of the time. Even those who behave badly know they're behaving badly, with a few exceptions who are just very bad. And we've got systems now we're learning all the time about how to make sure we identify the very bad ones. The doctor who kills lots of people, we have had them, as you know. But this is about codes of conduct, not just written down, but really believed in the heart. And I think the more you can expect and help people, and everyone is saying about Libya that this is a country now where everyone wants to do something fantastic for their country, to develop that sense of belief in doing the right thing for patients and for each other is critical. But you do need that system at the end, the disciplinary system that says, if you're really bad, you go. You're no longer a professional. You've got to have a way of striking people off. But clearly, that's the really negative end. The positive end is how can you incentivize people to work really, really well? And clearly, a pay scale, deciding your pay scale is critical. So are people paid a reasonable amount for what they do? Developing this culture of really believing in the Libyan health service will be a critical part of it. I think keeping people interested in what they do by offering a greater variety of opportunity is important. If you want people to work in the remote areas, I was talking to someone who works in primary care in the ministry last time I was here in March, and she said that a lot of primary health centres in Tripoli may have 6 times the number of doctors they need. And she said places in the remote areas will have 0 doctors in a primary health centre. So the distribution is a really big problem, as we're hearing. So how do you incentivize someone to go and work in the more remote areas? And it's providing people with rotation and different opportunities that will be really important, as well as money, perhaps. And I know that's really difficult to achieve. But having as much variety for people may be one way of keeping people moving around the system and going to having a variety of experience, but also helping spread the distribution of staff. We also don't pay people more money automatically anymore. We used to have a system where another year, more money. Certainly for nurses, for a lot of others as well. And now we don't do that. You have to go through a gateway that says you have increased your competence before you get the extra money. This is not just promotion, this is just moving forward in your own grade. You have to show that you've increased your competence. We have a clinical excellence award system. People may know about it. It isn't very good, actually, I don't think. It rewards people for coming to international conferences, for example, but it doesn't necessarily yet quite focus on performance sufficiently, in my personal view. I expect a lot of doctors in the health service would disagree with me, but we do pay quite a lot of extra to doctors, a lot extra. It could be even 100% in some cases for really fantastic achievement, and we need to make sure we're using that well. And then, of course, we have got these systems which were referred to earlier about how to make whole teams, like primary healthcare teams, improve. And that has really worked with primary care, where the quality and outcomes framework has given primary health teams more money if they achieve certain results, if they make sure all their diabetes patients are properly checked very regularly, for example. But there's also increasingly this thing we're calling patient-related outcome measures, or PROMs. Now we're getting to a point where we'll be able to say to individual clinicians, but certainly teams and certainly whole hospitals, your patients don't like what you're doing about a particular thing. It might be the emergency room, it might be diabetes treatment, for example. Your patients don't like what you're doing. And that power of patient feedback, being able to give that very quickly, very simply, and increasingly we're experimenting with apps on iPhones and things like that, where patients can very quickly give a response to their experience, will increasingly measure the performance of whole hospitals, but also of individual clinicians. And I think that'll be a very powerful incentive. People want to do their best for patients. But it's also obviously about money. So this is a big job to do. We're very pleased and happy if we can help at all. We do have, obviously, organisations who are keen to do that. People in the NHS organisations like Birmingham, you were hearing about earlier today, who are keen to help with this, have had experience of working out what staffing they need and how to incentivise their staff and how to give them the information they need. We've also got the Centre for Workforce Intelligence, who'd be very pleased to come and talk to you about developing your overall profile for health staff. We've got a new system just coming in for commissioning from universities. So our local education and training boards, which are being set up through the Department of Health, are there to, the department would be keen to help and advise on how you commission really good education for health services, health staff. We've got a lot, as you know, of providers of healthcare. There are 20 universities who would like to work with you. There are 20 universities in the UK ready to come and visit in the next few weeks, who want to come and work with you and see how they can help, both supporting training here in Libya and where appropriate, people going to the UK for training. So we have 20 universities. The Royal College is already working with you. Some would like to do a lot more. And clearly NHS organisations, a lot of them are ready to take people on, for example, visiting learning experience, professorships, and so on, with professors coming here, professors being available there, and fellowships for people to learn more, all the way through to advanced training for nurses and so on. So both coming to Libya for training, to advise on training and give training, but also inviting people back to the UK. And in terms of regulation, you'll know again that we have a big system, the GMC in particular, but also similar arrangement for nurses and midwives, and Nurses and Midwifery Council, a new, well, it's just expanded, a new Health and Care Professions Council for everyone else. And indeed, we have a regulator of regulators. So the Council for Healthcare Regulatory Excellence is a regulator of the regulators, just to make sure. So that's trying to keep patients safe, and that's critical, isn't it? So I hope that's been of interest. I'd be happy to discuss it with anyone in more detail in the time available. We obviously are limited, but we stand here very ready to support you in this fantastic endeavour for the new Libya. Thank you very much.
Thank you, Chris, for the nice presentation and very informative, valuable information. I think we have time for a couple of questions.
Just I want to ask about the rule of motivation of the human resources in regards to the rule of the government here. In Libya, if we are stick to the rule, the problem of incentives to the performance will be very restricted. So what do you think if there is some kind of contract between the government, I mean in form of the Ministry of Health, to improve the performance, for example, for the primary health care or family physician, to contract with certain companies, which is not available now, and they can give incentives. Just the Ministry of Health will be in charge of putting the regulation and standards and monitoring of the quality of the services and efficiency and effectiveness of service, and they will contract with these private companies to do that, because they will be more flexible in dealing with the people according to the performance and incentives, and they can contract upon the periphery cities, which needs more incentives than the central cities. Thank you.
Well, we're certainly experimenting with that and experimenting with using more private companies. I mean, obviously, as you know, primary care in the UK is independent contractors, but most of them are 100% funded by the state. But we are using more private companies and trying that, providing primary care and community services. So, for example, Virgin Healthcare is one that springs to mind. So, and of course, they are then free to try different methods. It's very much about making sure that you've got the performance as well as the reward. So often there's a strong emphasis on performance, particularly relating to what patients particularly want, as well as reward. The key thing I think you have to be careful about is making sure that there's no perception from the public that individuals are making themselves rich from public money. It's as simple as that. So making sure that it's not an opportunity for people to get rich on a public contract is the key test. So I think there has to be safeguards, but it's certainly something that's worth looking at.
Any more questions? Okay. Thank you, Chris, once again. So we'll move on to the next presentation.
Yes, our next speaker will be Dr. Badruddin Abu Hajar. He is a member of the teaching staff of Tripoli University, and he is a consultant urologist. I always like to introduce him, not because he is a consultant urologist, of course, but because he is the founder of the Quality Office in the Ministry of Health. And that was a few years ago. And he retired, and no wonder why. I don't blame him, actually. And quality and human resources are closely related, and he is going to talk about how to recruit and retain staff in health. Please welcome Dr. Badruddin.
Assalamu alaikum. Mr. Chairman, ladies and gentlemen, thank you very much. Well, I would like first to thank Mr. Kress about his comprehensive presentation. The problem that he said almost everything, so he doesn't leave anything for me to say. So I would like to redirect my presentation that might say something helpful today. Thank you very much. Yes. Well, the title of the presentation is a question, really. In fact, it's two questions. To start with, I would like to define staff. Well, I'm a bit interested in quality, so I will use the definition of quality. Staff is an internal customer. And as we all know, that the first definition of quality was customer satisfaction. So to retain your staff, you have to satisfy them. And I believe this is simply the answer of the second part of the question. Well, how to satisfy your staff is a quite long story, needs probably more than one discussion group to reach that aim. Well, 6 million is a number that I believe very important and should be in mind wherever we plan for the health service. This is our population in 2012. And we are going to duplicate this number in 30 years' time. So I believe we have enough time to do the job. Well, as Mr. Kress said, everything about the planning and everything about the education, training, and about the human resources, well, I would like to give some figures from what is the situation in Libya here. This slide, you have seen this slide with Dr. Abdulrazak Shlebek yesterday, and I would say the total number of employees is about 107,000. 10% of them, probably 11,000, are doctors, while about 40% of them are nurses, and just less 40% are management and services. Well, let us go a bit in details for these numbers and to see whether I have the right to change the question how to recruit people. Do we need more people or not? Let us see these numbers in details, and, well, you ask me whether I have the right to change the question or not. This is El Batnan Hospital, which is a bed capacity of 420 beds with 1,012 administratives. while in Misrata Hospital here, which is 480 bed capacity, is 155 administrators. On the other hand, we can see here that there is 480 beds in Sabha Hospital with 284 physicians. That means one physician for each 2 beds. If you come down a bit down here, you can see in Al Bayda Hospital, for example, which is 426 beds, you can see physicians, 230 physicians, 649 nurses, which I mean 1.5 nurse for each bed. While this number in Al Marj Hospital, which is a nearby hospital, there is only 53 physicians here. Next. Well, this is the Tripoli Medical Center and Benghazi Medical Center. Okay. And the number of physicians here is 996. This is in 2010. Probably now there are more than 1,500. I wouldn't ask about these figures there, but let us see the next slide and see Al-Afia Hospital and Brak Hospital. Brak Hospital is a bed capacity of 120 beds with 238 administrators. While the next door, Al-Afia Hospital, is with 59 administrators. I mean, numbers are, let us see the last slide here, which is from Tripoli, Dr. Khalid Maghboub, the director of Pediatric Hospital. I hope he is here. Okay. The Al Jala Pediatric Hospital with the 200 beds, there are 256 physicians. That means more than one doctor for each bed. And there is 276 nurses. That means still more than one nurse for each bed and 214 administrators. Mr. Kress, can you solve this problem? Well, the international figures here, Coupa, as you know, provides a doctor every 170 residents. And USA 2.4, Canada 2.2. My source say that in Libya there are 19 doctors for each 10,000 population, while in Jordan is 14. And in Tunisia, our neighbors, where all Libyans go to treat themselves, is 11.9. There are 9 medical faculties in Libya, with a total of 25,918 candidates by 2008. That means by the next year, we will have 25,008 plus the number which is there already. We have 37 doctors, 241, with approximately 400 to 500 doctors graduated annually from the medical faculties of Tripoli University only. Well, nurses. There are no nurse to patients ratio. I didn't find any that ratio in the internet really. But as far as I know, the ICU patients, 1 nurse per 2 beds or 1-to-1 for patients on ventilator, and this is a well-known standards. So according to the figures here, we have a nurse for each bed in some hospitals here, as if we are in the ICU, I mean. Well, the number of beds in Libya is about 20,000 something, and the number of nurses is about 40,000, so that means there are 2 nurses for each bed. If you imagine that the primary health care would take half of them, 20,000, so the rest is 20,000, that means 1 nurse for each bed. Do I convince you that we have to change the question, do we need more staff or not? Well, the administrators, We have 34,000 employees, yet catering and cleaning are outsourced, so they are not included in these numbers. And suppose or imagine that we use the hospital information system, and the burden of employees that will burden on the system as well. So we can observe the misdistribution of manpower. So the question is, we need to reorganize what we have already, putting in mind the annual outcome of doctors and nurses. Well, doctors, rural and urban areas, hospital and incentives. Dr. Chris, if you help me, what are the incentives that we can give for doctors so that they can go to the remote areas? Well, we have a clear shortage in some specialties. We have a hand count radiologists, I mean. And as far as I know, we have no a traumatologist at all. But we have plenty of general surgeons as well. Chronic GPs.